Well, we'll get started. Good evening. The 15th summer presenting this Healthy Living Lecture Series, which means over 100 local experts on health topics important to Alaskans these past years. I'm Mike Powers. I'll be introducing tonight's speaker, but first, you should know tomorrow night, as part of the Discover Alaska component of this lecture series, Tia Tidwell, Assistant Professor of Alaska Native Studies, will be presenting The Land Loves You, Honoring Relational Responsibility. Thursday night, Music in the Garden. This week features artists from the Fairbanks Summer Arts Festival, both starting at 6 and then the second set at 7:30. And that is, for those who haven't been to Music in the Garden, really make a point. It's just a fabulous weeknight program. And then I just heard from Michelle Bartlett on Monday, this is August 11th. This is a special add-on presentation. Dan O'Neill in conversation with Dermot Cole. Dan O'Neill, obviously the incredibly insightful Fairbanks author, is back with a new book, The Impertinent Question, The Words and Adventures of a Liberal Columnist at a Conservative Newspaper in the Red State of Alaska. Now, Dan O'Neill, of course, wrote Firecracker Boys, The Last Giant Beringia, The Lady Long Lonesome, Stubborn Gal, and this will be a fabulous discussion. And this is Tuesday, Monday the 11th. So keep that, Monday, August 11th, right?
At 7?
At 7, yeah. And I'm assuming it's in this room, but it's going to have to be, obviously, carryover capacity because it'll be a popular one. The book, by the way, 40 years of columns. I was talking to, what was it? Former admin up here who said just an incredible book. He had already picked it up. But so let me introduce tonight's speaker by way of a little Fairbanks cardiology history. Some of you know this. Cardiology has always been discussed as a needed service in Fairbanks going back to the '67 flood, which prompted the planning and rebuild of Fairbanks Memorial Hospital. 25 years ago, after things settled down from the oil bust of the mid-late 1980s, planning really started getting serious, largely driven by a call from the community for more advanced medical services. To gain approval for the project, the health planner that we were working with from lower 48, and who had spent time on local rivers, Volcanic, Lutina, and Nanachina, knew the interior well, was paying attention to what was going on at Johns Hopkins, and Dr. Thomas Aversano was conducting an empirical study of standalone cardiac cath labs functioning without surgical backup on site. It appeared that Fairbanks might be a candidate for such a program. Dr. Aversano was invited to Fairbanks, began making the rounds, meeting with local physicians, Anchorage physicians, local board and community members, State of Alaska Department of Health and Social Services officials, and then after considerable planning with some highly skeptical physicians and some fairly vocal pushback from Anchorage physicians about advancing these services without cardiac backup in Fairbanks, the hospital with Dr. Aversano's study and Dr. Mike Carroll and Rich Berger in particular were instrumental in helping pull this off. So the hospital recruited Dr. Rick Latham and opened Alaska's first standalone cardiac cath lab, which was, if not the first west of those East Coast seaport trial communities, one of the very first west of that East Coast, and then ultimately cleared the way for relatively small communities across the U.S. to offer cath lab services without surgical backup. But a key milestone, I believe, in FMH cardiology service was achieved when Dr. Romel Wrenn joined the effort, and he's been the bedrock of the cardiac program here in Fairbanks ever since. Dr. Wrenn received his medical degree from Tulane School of Medicine. He's been in practice more than 25 years, widely recognized as a highly skilled cardiac physician who's actively engaged in the Fairbanks community, approachable, committed to advancing the program. And just for the sake of tonight's talk, I asked a highly respected primary care physician, whom many of you know in the community, Just why is Dr. Wrenn so well thought of among his peers? And I was told, outstanding champion of cardiac care, accessible, easily approached, trusted, collaborative, thorough, and he always says, yes, I can work with you when I call him looking for help. And that's what his peers say about him. So please welcome me for the much beloved Dr. Romel Wrenn, whose talk is titled Staging.
Hey, Jeff, this Michael? Yeah, the mic's okay. So there's no clicker to advance the slides. So Jeff, who's moving away in a couple of weeks, is going to be doing this. So I can't threaten him, right? He's leaving. Rick Latham was my mentor in that he was my advisor for my research project that I did to finish my fellowship in cardiology. And Rick invited me to come here, and for professional reasons I came because Rick Latham and Joe Johns were two guys who were a year ahead of me at Brooklyn Medical Center, and we were trained the same way. It was, Joe Johns would say, low volume but high quality. That's what we wanted. So Joe has passed on now from a malignancy. Rick had moved away and then invited me to join him in Idaho Falls. And I said, Rick, I don't want to move again. And in fact, I'm buying a house. He said, buying a house? Why didn't you buy my house? So, I didn't answer. But my plan was to come and stay for 3 years, and it's been 13 years now. So in terms of AI, last year I talked about AI, and Mayo Clinic joined with a company called Inference to form a new company for AI ECG called Anamana. So I wrote a research proposal to Anamana to look at AI in people with stage A heart failure. And they thought it was a very good thought, and so they're coming up to visit to see if we can make this work out. So tonight's talk is actually on stage A heart failure. Have you all heard of stage A heart failure? No. So this staging system probably came out about 20 years ago. But most physicians won't talk about stage A heart failure because you don't feel good about telling someone with high blood pressure, you have stage A heart failure, right? I mean, that would frighten a person to say you have heart failure, but it's stage A heart failure would include those conditions that can lead to heart failure. What's nice about it is that it gives you an opportunity to prevent heart failure if we really focus on these things. So tonight we'll talk about stage A heart failure. Jeff, next slide, our first slide, if you can find it. Okay, let's go to the next slide, Jeff. So the goals for tonight would be to define heart failure, explain the scope of the problem we have with stage A heart failure, talk about the stages of heart failure, and give an introduction to the management of stage A heart failure. Sure. So how do we define heart failure? Well, it's a clinical syndrome resulting from structural or functional problems with the heart that would lead to the inability of the ventricle to eject or to fill with blood. Ejection is important, but filling is important also. Next slide. So what's a syndrome? Well, a syndrome would be a group of symptoms which consistently occur together, or a condition characterized by a set of associated symptoms. So in heart failure, those symptoms may be shortness of breath or dyspnea, decreased functional capacity or reduced exercise tolerance. And then we can, of course, those symptoms may be due to other things. For instance, it's not unusual for someone to be referred to cardiology because of shortness of breath and can't do much, and then we do full evaluation and find, well, this person has profound anemia. So anemia, they may do it, or maybe a pulmonary problem. But we can do testing and look at B-natriuretic peptide, BNP or NT-proBNP, and that helps us to make a diagnosis of heart failure. We can do, of course, examine the patient, talk to the patient, and do chest x-rays and that sort of thing. Next. There's a high burden to our society because of heart failure. Next. So there are about 6.7 million adults in the U.S. with heart failure. Now, according to CDC, half of adult Americans have high blood pressure, but only about 5 to 8% of adult Americans have heart failure. But the cost of heart failure is so astounding that it costs about, this was the next slide. The cost is about 40 billion annually, and is expected to go up to about 70 billion by 2030. The cost for treating high blood pressure is in the range of about 180 to 200 million. Next. So there are about 1 million hospitalizations annually in the U.S. because of heart failure. 25% of the patients are readmitted within 30 days. Patients have multiple comorbidities frequently with heart failure. You're going to have kidney disease, diabetes, chronic obstructive lung disease, anemia, depression, and there's a significant functional limitation in about half these patients. And there's a high burden of symptoms causing patients to go to the ER over and over again because of shortness of breath. Next. Mortality is high too. Because of newer medications, the numbers may be a little better than this, but 1-year mortality may be anywhere from 20 to 30%. 5-year mortality, 50%. We have to use 4 or 5 different medications to treat patients with heart failure with reduced ejection fraction. There is a heart failure with preserved ejection fraction. That is, the squeeze is still good. There are only 2 medications for that, really. But the 5-year mortality rate may be up to 50%, particularly in patients who cannot afford medications or patients who refuse medications. And mortality rates are even higher than what we see with many cancers, such as breast and prostate cancer. Globally, there are more than 64 million people with heart failure. So, heart failure is costly, it causes significant morbidity, it's deadly, and what we need to do is to focus on stage A and stage B heart failure. Now, stage A, let's go to the next slide. Okay, so first, types of heart failure. Well, there's heart failure with reduced ejection fraction. So when the heart squeezes, it should pump about half the blood out. So we say ejection fraction should be anywhere from 50 to 60%. If the ejection fraction is less than 40%, some would say even less than 50, less than 40%, there's heart failure with reduced ejection fraction. If the ejection fraction is greater than 50%, but there are symptoms of shortness of breath, elevated venous red peptide, we have heart failure with preserved ejection fraction, which is more common in women than men. And we have ways of determining this with echocardiography, along with lab testing to determine this. And it's not an unusual cause of shortness of breath. And there's heart failure with mildly reduced ejection fraction when the squeeze is 41 to 49%. There could be right-sided heart failure and left-sided heart failure, but left-sided heart failure is more common than right-sided heart failure. Meaning, when we say right-sided, it's the left ventricle, which is the primary pumping chamber. The right ventricle is primarily a volume pump, but it can fail sometimes too and cause right-sided heart failure. And there's acute or heart failure that comes on suddenly, and then maybe chronic or acute on chronic. Someone with chronic heart failure who will go out to eat, and of course there's generally too much salt in food, and then one may retain fluid and have an acute onset of heart failure. Yeah. So the stages, there's stage A, stage B, stage C, and stage D. So stage A are those patients at increased risk for heart failure but don't have any structural problems and don't have symptoms. Stage B would be individuals with structural problems such as aortic stenosis, valvular heart disease, they may have had a prior heart attack. Those are patients with structural heart disease. Someone with a very thick ventricle from long-standing high blood pressure that may have gone untreated. Stage C would be people with structural heart disease who have ongoing heart failure or previously diagnosed with heart failure. And then stage D are those patients who have intractable heart failure. We have at least one person in the community who has a left ventricular assist device, a HeartMate 2, because of his heart being extremely weak. And he's had it now for probably about 3 years, and he's doing very well with that. Next. So stage A, heart failure, refers to individuals at high risk for developing heart failure, but who did not yet have structural disease or symptoms. And the focus should be on prevention of structural changes and progression to heart failure. Next. So what are the conditions that will place individuals in stage A heart failure? Well, high blood pressure. That's a lot of people, right? Half of adults in the United States with high blood pressure, so are at risk for developing heart failure. Atherosclerotic heart disease or cardiovascular disease, including coronary artery disease, diabetes, obesity, metabolic syndrome, exposure to cardiotoxic agents, genetic variants for cardiomyopathy, and family history of cardiomyopathy. So these are the individuals with stage A heart failure. Next. So let's talk about first hypertension. Jeff. Next slide. So hypertension, also known as high blood pressure, is a condition where the force of blood against the artery walls is consistently too high. It is defined as blood pressure readings of 130 over 80 or higher, or a systolic reading of 130 millimeters mercury or higher, or a diastolic of 80 or higher. Next. And so normal blood pressure is considered to be less than 120 over 80. Elevated blood pressure, 120 to 129, systolic, but diastolic is still less than 80. Stage 1 high blood pressure would be having systolic pressure of 130 to 139, or diastolic 80 to 89. And stage 2, systolic greater than or equal to 140 millimeters mercury, or diastolic greater than 90. So those are the parameters we use. Now, how does the heart respond to the stress of high blood pressure? When the heart is stressed, a normal response would be physiologic hypertrophy. That is, the muscle enlarges, but the chamber enlarges somewhat too. Concentric hypertrophy, which is the type of hypertrophy we don't like to see, is where the muscle thickens, but the chamber does not change in size. Or the response may be eccentric hypertrophy, where the chamber enlarges and the muscle just thins out. We see this more often in terms of eccentric hypertrophy, and people using methamphetamines. So these are the three responses, and these are the two that we do not want. Next slide. So there are various studies looking at treating patients with high blood pressure and being aggressive. That is, lowering blood pressure to 120 over 80. And then, is that better to do, or should we just say below 140 over 90 is okay? Well, in these studies that were done, there were good results in terms of lowering blood pressure, but there were also severe adverse events. And these events were having low blood pressure, feeling faint, passing out. There was not death, but they would cause severe adverse events if patients had those type of symptoms. And what was found, let's go to the next slide. When you look at the evidence in some of these studies, is that if we lower blood pressure to less than 120, there were significant cardiac events. Now the SPRINT trial, excluded patients with diabetes or prior history of stroke. In the ACCORD trial, they looked at patients focusing on people with type 2 diabetes, found that intensive blood pressure lowering to less than 120 did not reduce the rate of cardiovascular outcomes, so it was not really better than 140. Overall, though, when they look at the various groups of patients, they found that while intensive lowering showed benefits in some populations, it was also associated with increased incidence of certain adverse events, such as low blood pressure, loss of consciousness, and acute kidney injury. So if we're too aggressive, that can be an issue. However, next slide. Here's a study from the American Heart Association and American Stroke Association looking at the benefit and harm of intensive blood pressure control by cardiovascular risk. And they broke the risk down into various tertiles. Next. And what they found was that in conclusions with looking at over 8,000 patients for over 3 years and breaking down to the risk of having a cardiac event, higher cardiovascular disease risk was associated with increased benefit and also harm from intensive blood pressure control. And although the benefit and harm profiles varied across the various levels, the overall benefit was greater than harm in all. So overall, if we lower blood pressure to less than 120/80, people tend to do better. I recall several years ago, a patient was a bit upset, came to the office, and she had fallen and had broken her arm. And so rightfully so, she was upset. Someone had inadvertently given her an angiotensin receptor blocker and also an ACE inhibitor, which we don't do. So she suffered a drop in blood pressure and broke her arm. She still comes to see us, and that was a long time ago. But things happen, you know. I recall a physician I worked with many years ago, and he was still considered me a friend, came to me because of high blood pressure, and I put him on one medication, and he went to New York and passed out. But he did okay. I mean, he still practices. So it happens, right? In terms of, yeah, just speaking of a personal thing, I was fasting for 36 hours, and when you fast, you shouldn't take certain medicines you shouldn't take. Maybe you shouldn't even take medicines. But, so I was fasting, and I was doing a cardiac catheterization. I had all this lead on, my collar was tight, and I kind of felt warm. I stepped away, and then next thing I knew, people were shouting, trying to decide whether they're going to do CPR or not. And so they said, we can't get his blood pressure, can't get his blood pressure. And I reached over and touched my pulse. I said, it's 120/80. And they checked it, it was about that. So they gave me a liter of fluid, told me to go home. I didn't go home because I had a lecture. I had to give a lecture that night. And after I went home and changed, gave the lecture, and after I got back, then I explained to my wife and daughter there was a little bit of an event in the cath lab. So it can happen, right? But, one doesn't have to make a big deal of it. So it's good to lower your blood pressure. And if it's below 140/90, that's generally acceptable. But if you can, without symptoms, get it to below 120/80, that's even better. The lower the blood pressure, the longer you live, the less stress on your cardiovascular system. Next. So what about the role of diet in the prevention and management of high blood pressure? And there was a umbrella review of meta-analyses. An umbrella review is better because it takes multiple meta-analyses to look to see what the outcomes are rather than just one meta-analysis. Next. And this was published in the Advances in Nutrition, the role of diet in prevention of hypertension, management of blood pressure. And it's meta-analysis to see does dieting work and what diet would work. Next. And so they found that diet is a key factor in preventing and managing hypertension. And there was strong evidence supporting dietary changes as a non-pharmacological approach for treating people. Next. And what diets work best? And diets rich in plant-based foods, whole grains. I don't agree with low-fat dairy products at all. I don't agree with that. The Dairy Association is powerful, I tell you, it really is. And the reason I don't agree with it is that Colin Campbell, who wrote the China study, proved that if you want to make cancer grow, you give it milk protein. If you want to stop it, you take it away. And so, I'll get off that soapbox now. But next. So there are 3 proven diet approaches. One is and there's probably a 4th. One is the DASH diet, which is the diet against to prevent high blood pressure, to stop high blood pressure. And this is American Heart Association diet. The Mediterranean diet and also plant-based diets were proven to be effective in lowering blood pressure. And why do they work? Well, they work because there are a lot of antioxidants, and there's improved endothelial function with this type of eating. Next. The dietary recommendations for blood pressure: reduce sodium intake to within recommended limits. Try to not go above 2,000 milligrams a day of sodium. Many years ago, physicians thought that you have to drink to live, and this is true. But then, now we know you don't. You don't have to, we know that through the Seventh-day Adventists who don't drink. Dan Buechner, who wrote the Blue Zones, we found 5 places where people live a long time. Sardinia. Now the Sardinian males drink red wine at least 3 times a day, and they do a lot of walking up down hills, tending to goats. The wives carry the guns, so they have very little stress. So Sardinia, Costa Rica, Okinawa, Icaria, Greece, and then Loma Linda, California. And the reason for Loma Linda is the Seventh-day Adventists. So that's where you find people who live to be 100 who are still very healthy. But Buechner, as one of his recommendations was to have wine at 5, just to relax. And so some of the studies have shown that if it's not heavy alcohol intake, moderate amount is okay. Now, I know what Danielle is thinking. That's my daughter. She's thinking, well, but that's recent research is saying that no amount of alcohol is really safe. And the reason is that alcohol is a class 1 carcinogen. Because of that, it's been recommended that men can have 2 units. Women can only have 1 because the male liver can metabolize, break down alcohol faster and without having breakdown products that are dangerous. But there's reason suggesting that, well, that may not be as safe as one would think. But there are large studies showing that a small amount of alcohol is not detrimental. Next. And then there are other studies showing that plant-based diets reduce blood pressure, and this has been reviewed in several studies. Next. So the focus, the other is protein. We don't have to worry about protein. You know, when people used to, they don't anymore, with going on hunger strike to prove a point, and then die, and then they died when they ran out of fat, not protein. So if you eat a plant-based diet, you get more than enough protein. In terms of protein, that's the Voigt standard. Voigt was the German who felt that German workers were excellent workers, and so he did observational study to see how much protein the well-nourished German worker ate, and it was about 120 grams daily. And I'm blocking the fellow's name, but it's another observational study that was done in the U.S. By a researcher who felt the American workers were better than German workers, and so he looked at the American workers, and they ate about 130 grams of protein daily. So Chittenden, in the early 1900s, I think was at Harvard, and actually studied, did the actual very good research to see how much protein is needed to have a very nice physique, to be muscular, and to be healthy. And that was somewhere between 50 to 60 grams of protein a day. So we tend to eat too much protein. And then there's a difference too in terms of plant-based versus animal proteins. Plant-based proteins are linked to lower high blood pressure risk. High intake of animal protein is less beneficial for blood pressure. When when Colin Campbell visited with us, we were having a conversation, and he said, we now feel that any type of protein in excess is not good. It could be detrimental. So we should not worry about protein. Next. Okay, now, when you go to see your primary care provider, this is the thought process. If you have elevated blood pressure, systolic pressure 120 and 190, then we're going to use non-pharmacological therapy, exercise, healthy diet, less protein, no milk. Now, let's say you have stage 1 hypertension, and systolic pressure is 130 to 139, and you can do this online. It's an ASCVD risk analysis where you look at your age, your race, your gender, your systolic blood pressure, diastolic blood pressure. You need to know your total cholesterol, your LDL cholesterol. Sometimes they'll ask for HDL cholesterol. Are you diabetic? Do you have high blood pressure? Do you smoke? And you just put the information in, and it gives you your 10-year risk analysis. It's ASCVD risk. If your 10-year risk is greater than 10%, then you do non-pharmacological therapy plus a blood pressure lowering medication if you have stage 1 high blood pressure. If you don't have an elevated 10-year risk, then one can say, no medicines right now. Let's just try to lose weight, eat properly, reduce the amount of salt in your diet. If you're stage 2 hypertension, it's important that we know that not only will you add a medication, but you will add 2 medications, sometimes 3, for stage 2 hypertension. And if you want to be around, if you like your family, some of your friends, then you do this. You take your medicines and you get your blood pressure down. Next. Jeff. Okay. All right, let's go. Next, Jeff. I'll go back. Okay, so let's now go to cardiovascular disease, atherosclerotic cardiovascular disease. All right, next slide. So when we talk about atherosclerosis, we're talking about soft plaque. Now, I can't look at anyone in here and say, you have soft plaque. It's impossible. And this is a soft plaque. Whereas when we talk about arteriosclerosis, that's hardening arteries, that's hard plaque. Now, the problem with soft plaque is that it can be vulnerable. It can rupture. That's what causes a stroke or a heart attack. Next, Jeff. So, there can be inflammation within this, promotion of lipoprotein deposition into this plaque. The plaque becomes larger and larger, and the covering over this plaque becomes thinner, and then this plaque can rupture and cause an event. Tim Russert, remember Tim Russert with Face the Nation? And then he was about 51, 52 when he died suddenly. And so an autopsy was done to see what happened to Tim. And this next animation is from actually Tim Russert's, what they found at autopsy. The next slide, Jeff. And go back to the one that yeah, we want that. There we go. So that's his left anterior descending arteries where they found a ruptured plaque. So that ruptures, closes the artery off, and then one goes to the V-fib. And 30 to 40% of people with an acute MI never make it to the hospital, and that's what happened to him. He died. So his name came up in conferences I was going to because he had coronary artery calcium scanning. He had a coronary calcium score, which was elevated, placing him in the 90th percentile. And if you're in the 90th percentile, if you don't do something drastic to lower your cholesterol, lower your blood pressure, then there's a very good chance that you have an event within 10 years, and he did. He was about 41, 42 when he had the calcium score, and he died when he was about 51. So coronary calcification, we can see with a CAT scan. And so for men between the ages of 45 to 75, women maybe 50 to 75, we don't have to cut it off at 75 actually, but we don't need to do it when you're very young because young people, you have to age long enough to calcify. But this is a good test to do to see if you have coronary calcification. Next. So here I am, about to get my calcium scan. Next. Jeff, next slide. Okay, so the CT calcium score is a CAT scan of the chest to look for, to measure the amount of calcium that may be in the arteries to your heart. Next. And the question, so what does that scan tell us? Well, it tells you if you have hardening of the arteries. And the higher the level, the more likely you have atherosclerosis, that is a soft plaque. So if your score is 0, highly unlikely there's any soft plaque. If your score is 400 or higher, highly likely that you have significant soft plaque in the arteries. So if someone has a calcium score of 400 or higher, we say, well, we need to do a stress test, even if you have no symptoms, a nuclear stress test. And then we also want to lower the LDL cholesterol to below 80 is good, below 70 is very good, below 55 is excellent. So zero calcification suggests very low probability of obstructive disease and less than 1% chance of a heart attack and stroke over the next 5 years. So it's a very good test to do. It costs $120, and insurance companies, the hospital won't, you can file your own insurance. Insurance companies frequently won't pay for it. It used to be $500, but FMH reduced it to $120 to make it more accessible to individuals. Next. So if you have a coronary calcium score of 0, that's like a 99% chance you'll still be around about 12 years from now. Next. Keep going. So if you have a coronary calcium score of 1,000, then that drops to about 87% or 13% chance that one would have an event within 12 years. Next. Let's go to the next slide now. Okay, so how can we use this? Well, if you go and do that calculation to see what your 10-year risk is, if your 10-year risk is greater than 20%, then a statin is recommended. But if you have intermediate risk, where your risk is, let's say 7.5 to 20%, if your coronary calcium score is 0, one can say you don't need a statin, because the coronary calcium score tells us much more about the risk than just looking at your cholesterol, your age and race and gender. The American College of Cardiology, American Heart Association says, well, it doesn't matter. If your risk is greater than 20%, it says don't do a calcium score. It doesn't matter. You should take a statin anyway. But it is, worth knowing. And if you're, now, if your calcium score is greater than 0, if it's 1, 2, or 3, you still will use a statin in intermediate risk people. Okay, so that's how that test is helpful. Next. Let's go on to diabetes now. And so, what number do we look at with diabetes? The A1C, familiar with that? The hemoglobin A1C? Yeah, let's look at that. Let's go to the next slide. Diabetes, okay. Well, so the problem with diabetes is that you may get inflammation, abnormal lipids. You can get hypertrophy or thickening of the heart muscle. You get advanced glycation end products. Now, autonomic dysfunction. It's interesting because if the blood sugar is high for a long time, the sugar actually would coat, the glucose would coat the vagus nerve and will not function properly. So diabetics frequently have elevated heart rate because of glycation of the vagus nerve. And I didn't know until I was preparing for this talk that you also get glycation of cardiac muscle. What's interesting is that it's not reversible. Once it's now with the vagus nerve, it tends to be reversible, right? If you get better control of your diabetes, then you can reverse that. But long-standing diabetes with poor control, the glycation of the cardiac muscle is not reversible. And that leads to fibrosis and scarring. Okay, let's go to the next slide. So if you look at the A1C, hemoglobin A1C, if it's 6.5 or below, that's more consistent with long life, better life expectancy. I hate to say long life expectancy because in the U.S. we don't really live long, right? We don't. We begin getting sick in our 70s. Whereas in Sardinia, Costa Rica, Okinawa, Loma Linda, California, Icaria, Greece, they begin to get sick when they're 90 years old. So we can't let them outdo us. We have to work harder, exercise more, eat less. So, as the A1C goes up, life expectancy goes down. So that's a number to pay attention to and say, I don't want to have an elevated A1C. Hemoglobin A1C greater than 8.5 may lead to symptomatic hyperglycemia and problems. And we see this quite often. A1Cs are 9, 10, 11, 12. Next. So, you're familiar with the GLP-1 medications, Ozempic, yeah. And then there's Rybelsus. Also, there's a GLP-1 plus GIP, which is Zepbound or tirzepatide. Well, the body has GLP-1 receptors in various places in the brain. So the GLP-1 receptor, in terms of its effect on the brain, is that you get full faster, decreased appetite, increased energy expenditure, reduce inflammation in the brain. In the liver, there's less glucose production, less hepatic fat. In the pancreas, increased insulin secretion. In the heart, blood pressure goes down, myocardial contractility goes up, glucose uptake, endothelial function improves. In the kidney, improved intrarenal hemodynamics. So body weight goes down by 10%, maybe 20%. One issue with the GLP-1s is this, increase in heart rate. That may be a negative. Now some studies say that the heart rate only goes up about 2 to 5 beats per minute. We don't want heart rate to go up. In someone with heart failure, we would like to see the heart rate at 70, at rest, 70 or below is what we would like to see. So we can offset that with using beta blockers. And it's just not known how much of a detriment this is, but heart rate may go up with these medications. The other thing is that one may get sarcopenia, loss of muscle. So it's important for one to exercise also. We don't know, I can tell you this, in my career, in terms of taking care of sick people, and I've been doing it since 1976, as a junior in medical schools when we started taking care of sick people. This is the first time I've seen medications that will actually improve outcomes without hurting the heart. All other medicines that I have seen come on the market for weight reduction are not good, or detrimental. But these medicines, the GLP-1s, have reduced the risk of heart attack and stroke in diabetics. And people do get weight reduction, but one should remember that you have to change your lifestyle, right? Change how you eat, exercise, and that sort of thing. Next. So now there are also studies looking at the SGLT2 inhibitors, Jardiance. You ever heard of that drug? It's also Farxiga. Empagliflozin is the generic name for one of them. And dapagliflozin is the generic name for the other. Well, we have found that the SGLT, the sodium glucose transport inhibitors, are very important in heart failure. Not only heart failure with reduced ejection fraction, but also heart failure with preserved ejection fraction. In fact, with heart failure with preserved ejection fraction, the only two medications that really help would be the SGLT2 and a diuretic. Only two. We can use other medicines, but those are the only two that really work. So that's one thing to keep in mind. Let's keep going. The GLP-1 do have side effects. Common would be nausea, vomiting, diarrhea, constipation, stomach pain. It's amazing how many people don't really have. I mean, some have it, but they do well, and don't. I've seen many people on these medicines and without these complaints. But more serious side effects may be pancreatitis, gallbladder problems, kidney problems, hypoglycemia, low blood sugar, allergic reactions, bowel obstruction, gastroparesis. It happens. We don't see it very often. They're rare. Next, obesity. Let's talk about obesity. Jeff? Okay, obesity is a complex disease characterized by excessive fat accumulation in the body, which can negatively impact health. The World Health Organization defines it as abnormal or excessive fat accumulation that presents a risk to health. Next. Let's go to the next slide. This is, okay. There are evidence-based diets for weight reduction. There are 4. The Mediterranean diet, you can get weight loss, cardiovascular disease risk reduction, and which tends to last. The DASH diet, which is a diet for stopping hypertension, and weight loss, CBD risk reduction, low carb diets. So I saw a young lady today with a total cholesterol of 350 and an LDL of 263, and she was on the carnivore diet. And so when I saw that, and you say, you know what, okay, oh, here we go. What am I going to say? Because you don't want to run someone away by saying, what are you doing? You know, so so I said, do you know what your cholesterol is? Yes, I know. It's been high ever since I was a teenager, whatever. And then she said, I just want to try this to see if it's going to get better because it helped someone in my family. I said, fine, you have a plan. And when are we going to check it again, right? And so we made a plan. We're going to let her do that, and we're going to try it again. And I also said this, the diet can work. A low-carb diet, yes, you can get weight loss, because actually, when you eat a lot of meat, you actually have fewer calories than someone who's eating a lot of complex carbs, you know? So just like with Atkins diet, people lost weight, but it's not a healthy weight loss. And the risk reduction that happens, you can get it, but it's short term, right? And so we're going to try that. And then, of course, it's not going to work. And then we're going to get on a healthy diet also. Yes, kind of bonding, you know. You just don't want to run patients off. That's our future, young people, which is on 26. The Nordic diet, that weight loss and risk reduction, and yeah, I just said, what's that, right? What's the Nordic diet? Next. So Nordic diet is a plant-forward, high intake of vegetables, especially root vegetables and cabbages, fruits, seafood, rich, healthy fats, low in red processed meats, minimal processed foods, strong emphasis on reducing processed foods, added sugars and refined grains, local and seasonal foods are chosen. So, you know, it's very similar to being a pescatarian. The pescatarian Seventh-day Adventists do well as the vegan Seventh-day Adventists in terms of cardiovascular disease. So fish-eating vegetarians tend to do very well, particularly if it's wild fish. Next. So this is just something, most talks I'll have something there for me, and it's not really for others. But I don't want to lose it, so I'll just leave it in there. And so that's microRNAs and their role in obesity. It's going to be a decade or so before this is going to come to fruition. But they're going to be able to tailor the treatment of obesity to the person based on the person's genetics. All right, so what are microRNAs? Next. So microRNAs are small, non-coding RNA molecules that help regulate gene expression by binding to specific messenger RNAs and preventing them from being translated into proteins. One can affect these through epigenetics. It's just amazing what we can do in terms of our genetic code if we just knew the secrets to it. And so there's a lot of research being done now. Next. There's ongoing research into how microRNAs can be targeted for obesity treatment. Researchers are looking at ways to either block or boost certain microRNAs to help regulate fat metabolism and to reduce fat storage or influence appetite. It's experimental, but it's a promising area for future therapies. So we're just going to learn so much more, especially with supercomputers and it's just the future's going to be bright. Next. So microRNAs, I mean, they're throughout the body, of course. Next. And so the GLP-1s are the gold standard, but my prediction is that in 10 to 15 years or so, we're going to move on from that, maybe sooner, because medical knowledge is doubling every 73 days, which is astounding. Next. Let's go on to metabolic syndrome. Well, metabolic syndrome, next. Well, if you have high blood pressure, 3 out of 5 things. If you have high blood pressure, elevated blood sugar, and if you have a waist circumference greater than 40 in men or greater than 35 in women, that's 3 things. Then you have metabolic syndrome. Well, those are things we talked about, right? Obesity, high blood pressure, elevated blood sugar. If your HDL cholesterol, how do you know if you have enough HDL? It's simply this way. You take your HDL and subtract it from the total cholesterol, and you want that number to be less than 100. All right, so let's say you have a HDL of 80. I say this all the time. Oh, my HDL is high. Well, it's 80, but your total cholesterol is 200. Well, that's 120. You don't have enough HDL. The other thing, too, is that calculation holds true if you're not fasting. So when you get your cholesterol checked, there's no reason to fast. Cholesterol doesn't change much from day to day. We don't want it fasting. The lab will give you a hard time, so just tell them you're fasting. I do it all the time. You know? I mean, I had my labs drawn today because I didn't want to be a hypocrite. I wanted to check my lab to see what they were. And the young lady said, well, you're fasting. I thought, you know, I was. I had a meeting today, actually. I was too busy. Sometimes it's a problem. You know, I mean, not that I didn't eat, but to stop to eat. I mean, you know, I look at it this way. I'm at war. And what soldiers stop to eat all the time? You know? That's a known story, too. Because I was a soldier. Well, okay. I was in the Army for 9 years. I was a good doctor. I was a bad soldier. but I was. I mean, I was in for 9 years, and I loved every minute of it. So, triglycerides greater than 150. So you take 3 out of 5, you have metabolic syndrome, and these people are at risk for heart failure also. So we want to work on those things. Next. So, exposure to cardiotoxic agents. So we see patients once every 3 months from the cancer center to get an echocardiogram because of the agents that they're on. So they do a great job monitoring the patients to see if there's any effect on the heart. And we have a technique with echo called strain. We measure the strain on the heart. So the heart may not look weak, but if strain is reduced, then we know that, okay, you have to back off on the chemotherapy. Or now I'm recommending to the oncologists that there's certain medicines like spironolactone that studies have shown it works better than other agents to help the heart if someone has a problem with chemotherapy. Next slide. So if we look at some of the chemotherapeutic agents, and I tell you, the advances in cancer are moving much faster now than advances in cardiology in terms of what the oncologists are being able to do to cure cancer or slow it down with some of the newer therapies. The HER2 chemotherapeutics can cause cardiomyocyte death. Alkylating agents may cause thromboembolism, cause blood clots. Platinum-based therapy, which they use in some types of squamous cell carcinoma of the lung, can affect the blood vessels. Next slide, this shows it a different way. Some of these, here's some of the cancers that's treated with certain drugs. But the oncologists are really on top of this. And once every 3 months, particularly patients who have been treated with breast cancer because of the agents they take, we get a limited echo to see how the heart is doing and to monitor the patients to avoid problems with chemotherapy. Next. This next slide. Genetic variants. So Mayo Clinic has a meeting called Genetics in Cardiovascular Disease, and every year I go and I would present 1 or 2 cases from interesting patients. And so last year, I presented a case to them, a 45-year-old, with an ejection fraction, should be 50% to 60, his was 12%. And a family history of heart failure in his father, and he had ventricular tachycardia, unsustained VTAC, on his monitor. Next, we did genetic testing, and we found that he had a malignant variant in the Titan, this gene. And it was likely pathogenic. And what's interesting is that the recommendations from the Mayo people was that, you know, he must have done something to stress himself, because Titan is a huge molecule, a protein, a huge protein, and you can do things to it and it still turns okay because it's so big, unless you really stress it, like a lot of alcohol or whatever, which the patient denied. However, when we treated him, he did improve, but we do genetic testing in many cases to look for problems in patients, which is important for the patient's family, right? To warn them that their kids and siblings. All right, next. So I have made a proposal to Anumana to use AI to detect low ejection fraction in stage A heart failure. The reason is this: if we say you're stage A, you don't have a heart problem. How do we know that? So if we can do an EKG and it shows us that your ejection fraction is low, well, you don't have stage A. You already have stage B. And we need to be more aggressive, because stage B people don't have symptoms. They wouldn't know it unless you did an echo, but an EKG is a lot easier to do than an echo. So my proposal is to use AI to detect low ejection fraction in stage A heart failure. Next. And the purpose is to evaluate AI ECG in detecting low ejection fraction in stage A CHF. Next. So we will take patients who have hypertension, diabetes, coronary artery disease, obesity, exposure to toxins, family history of cardiomyopathy, but no known heart failure, no known structural heart disease, and perform AI ECG, and we'll see the ejection fraction is greater than or less than 40%. If it's less than 40%, do an echocardiogram and let a different cardiologist interpret it. Not that I would be biased. I wouldn't be, but I'm atypical. And then we compare the AI, ECG, AI, LEF to echo and look at diagnostic metrics. And we reclassify the patients to stage B if the EF is low. And so we're going to hopefully start this study within the next few months. Next. The significance of this is early detection to prevent heart failure progression. That's the significance of doing such a study. Next slide. So, key takeaways. Identify stage A heart failure early so we can do, look at risk factors. If people with risk factors only no symptoms, we want to identify these people so that we can try to prevent progression to symptoms or structural heart disease. Promote a healthy lifestyle with diet, smoking cessation, less alcohol, no recreational drugs. Recognize familial and genetic patterns of cardiomyopathy, prevent progression with early pharmacological interventions when indicated. Thank you. Any questions? Yeah.
I just want to thank you for saying you don't need that much protein. I try to get 60 grams a day.
Yeah.
Romel, can you repeat that for the audio?
Right. The question is, oh yes, about we don't need, about protein and then how much do we need? Yeah, 60 is more than enough. It really is. Yeah. You know, so and actually I think in Alaska the average is somewhere between 120 to 180, but we don't need that. It really stresses the kidneys, and no. Yeah, so I have a shirt that says, I have 99 problems and protein ain't one of them. You know, yeah. Yeah.
You briefly mentioned something about if you're on dieting, or if you're really dieting, that you need to be careful of the medications you take.
Yeah, fasting.
Can you expand on that?
Yeah, fasting.
Diet?
Fasting. So one can safely fast. If you're fasting more than 3 days, you should have someone monitoring your lab work and monitoring you. So I feel bad that I was only at 36 hours, and so I need to go over again. But at any rate, it's another thing too. Like normally, in terms of water, you take your body weight, divide by 2. That's the number of ounces of water you need daily. If you're fasting, you don't need that much water. Things change when we're fasting. Joel Furman, familiar with him? Wrote the book Eat to Live. Furman wrote a book on fasting too, and I was in touch with him about coming to Fairbanks, and I said, hey, I want you to come give a talk on fasting. And he said, well, yeah, but I'd rather give a talk on reversing heart disease and reversing diabetes. And the foundation signed off on it, and he was supposed to come in August of 2020. Well, but that was COVID, right? So we just put it on the back burner and never got back to it. But I think we should have someone like Joel Furman come. The only issue I have with Joel, he's excellent, and we've been in touch with email for over 10 years, never been met each other, but the only problem I have with him is that he sells things, right? You know, he sells items. And when you sell things, you know, you can't promote them. But he's excellent. He's written quite a few books. He calls himself a nutritarian. And his programs are very good. There was, oh man, it's another, from Santa Rosa, California. John McDougall. McDougall, you know, familiar with him? Yeah, well, he was another health guru. He passed away just recently, but he was another one who would have come. And then Caldwell Esselstyn wrote the book Prevent and Reverse Heart Disease. I got in touch with him, and he was going to come, but his wife said no. Yeah. And she said because he's so tall, he's 6'5", or something like that, and she said, you know, he had both knees replaced, and those long flights to get him. That's the excuse she gave, but so we're going to get someone to come, and it'll be great, right? Have someone to come to the community and talk, and the foundation will. Oh, by the way, foundation, I was going to say we pay for it or we get donations. By the way, Jeff Cook wanted me to remind everybody that we still need to raise another $1 million for the PET scanner, for PET CT. So I don't know if Jeff is. So it's on tape, Jeff, that I said that. 1 million and counting. Okay.
Dr. Oz up here.
He likes milk. Yes.
You mentioned that you were fasting for 36 hours. Why?
So there was a cardiologist visiting, who's a health guru also. In fact, he just climbed Everest, and he likes to fast, and I like fasting also. I mean, it's really, you know, you meditate better, you just think clearer, and you focus on other things. In fact, when I met Dr. Esselstyn, he told me he wanted to go to Santa Rosa, California, and do this 5-day fast, but you're monitored, right? And the person who has fasted the longest to lose weight did it for, it was like 320 days, and in that range. It was published in a journal. He lost over 180 pounds, and after 4 or 5 years or longer, he still kept most of that weight off. But he was given, from time to time, he was given some IV solutions, and he had no food, but he did have, of course, water. But over 300 days. Yeah. You know, we used to wear the jaws in people. We actually did that. The last time I had that done to a patient, but actually I've also done bloodletting with people with heart failure before we had strong diuretics. Where I would put a large IV in, take off a unit of blood in someone with severe heart failure, and you can see within 30 minutes they could breathe, you know? We don't do those things anymore. I never put a hole in anyone's head. Well, I did once. I mean, I did neurosurgery once, did put a hole in a guy's head, but we took the cancer out. Next.
Yeah, is there any fasting group? I encourage them
I'm sorry, you have a group?
No, I don't. But I mean, you are fasting, but I mean, is there any
Group?
club fasting group? People
Oh.
get together, encourage.
I don't know. You want to form one? That we should do that.
Because I did 1 week fasting before I came to United States. I lost 15 pounds. But because the diet changed,
Yeah.
well, from Taiwan to United States, and my weight has decreased.
Yeah.
I mean,
Yeah, fasting can be good. It can be dangerous though if you're on medications. It's not something that if you're on several medications, you should not do that unless you're under a physician's guidance. Next.
So you mentioned protein. I just want to come back to protein because it seems like when people become older, they need to have more muscle or maintain their muscle, I should say. And they say one of the ways to maintain muscle is to eat enough protein, especially as we get older. So how does that work, in your opinion, for older people?
Yeah, so that's a good question. We do lose muscle, a certain percentage with decades. One thing is to do resistance exercise. Now, we lose fibers. I mean, I may want to run fast. I can't. I mean, I can outrun my granddaughter, but well, I don't have I can outrun my grandsons too. But at any rate, we lose our capacity to breathe. We lose our VLI. The aging process is really a problem. We lose things, and we can't build muscle the way we used to. We can't. However, if we are going to use protein, it's better to use plant protein. What's the difference? Well, animal protein has more sulfur bonding, and because of that, when we have animal protein, we have release of production of more homocysteine. And homocysteine is a caustic amino acid which causes increase the thickness of blood. You're more likely to have blood clots, and you have more inflammation in the body just from homocysteine production. So that's a one significant difference in the two. So if we are going to use additional protein, it should be plant protein that we do. However, make sure you have your name and your number, and I'm going to research this to take in terms of what else we can do, because I need to do it too, right? In terms of maintaining muscle mass. Now I do push-ups. Do you do push-ups?
No, I don't do push-ups.
But and then now I'm beginning to have a inversion table. And so I'm up to doing 40 crunches on that in the morning. You have the inversion table? You just do things like that. So, but I'm going to research that. It's just fun researching things to find out the answers for them, right? Those things. A physician came by my office a year ago, and he said, I work out and everything, and he said, but when we get to a certain age, you don't get the same results. And then another physician called me the other day and said, hey, man, all the doctors in town are taking testosterone. What's going on with these guys? I said, well, I'm not taking testosterone. I mean, so that's, so we just don't build muscle the way we used to when we were younger. And I'm not saying do testosterone. I don't. I'm not saying it's wrong, but I haven't studied all of that. I mean, I'm really focusing on the heart right now. But the question is, how are we going to build protein as we age, right? Okay, I'm going to research that. And then actually, we did have someone, one of the top people in the world on aging, to come, Michael Fossil. And we should have. Were you here when Michael Fossil came? Yeah, he came about 4 years ago. I invited him, and he gave a talk on aging, and he talked about telomerase. And telomerase, he thought, was going to be the enzyme that was going to cure aging. And he thought that was going to happen within a year of his coming, and it's been 3 or 4 years now. So I need to get Michael to come back and say what happened, and because aging is it's an issue. Right, yeah. I'm sorry, next.
Maybe it's an excuse, but hearing that all the blood pressure levels you talked about in there, especially the 120/80, is that younger people, do older people really naturally have a higher blood pressure, or is it just an excuse?
Yeah, so that's a great question. I had a patient say to me 2 weeks ago, why is it that you take a man who's 6 feet 5 inches tall, and you say his, and his, the brain is higher, it's further away from the heart, and you're going to say 120, it's going to be the same blood pressure for that person as normal than a smaller person, and I said, yeah, and because we do say that, but why? Why is it that way? Well, it's because of arterial compliance. And that is, when the heart squeezes, it pumps out, during systole, the arteries, the large arteries dilate, and they absorb part of that energy. And when the aortic valve closes, and the heart is filling again, those arteries then squeeze, and they form secondary pumps. And so to get this answer, actually, it took me hours, but through asking questions to AI, whatever, and I said, and I just kept getting answers, well, but no matter what the body size, blood pressure is, the same number is considered normal. But then I said to AI, but don't the arteries have compliance and sort of serve as a secondary pump? And it said back to me, yes, that's called the Wrenn-Kessel effect. Wrenn-Kessel effect. So, if your arteries are youthful, despite your age, if your arteries are still compliant, then they do serve as secondary pumps, and the blood pressure should be the same no matter, it should be normal, around 120/80. It may go up a little bit, right? And now, of course, in younger people, it should be even lower in kids than childhood. However, the slide that showed the hardening of the arteries, arteriosclerosis, I saw a patient today, and her blood pressure was 180/80. Widened pulse pressure. Why? Because now she's lost her compliance. She was in her 80s, and so she doesn't have compliant arteries, she has pipes now. And if you have rigid pipes, you have to get a high systolic pressure. So there was a push to say, and actually, we do know this, if the diastolic, the bottom number, if it's below 60, that's not good. We have to let the blood pressure stay a little higher. That is as dangerous as having severe high blood pressure if you have low diastolics. We do not want the diastolic pressure to stay below 60. That's too low. So in a case like that, when the arteries are rigid, like pipes, then you have to allow for a certain degree of systolic hypertension. Some of the older doctors would say, you take your age, add it to 100, and that's the limit for your systolic pressure. Try not to go above that. Yeah. But we should exercise, eat a lot of greens, because that will improve endothelial function to whatever point we can. Yeah. Does that kind of answer your question?
Yeah.
Yeah, great, thanks.
Hi there. I guess I'm up to 33 trips out of the country, average 4 months a trip.
Mm-hmm.
Peru, Italy. And when I am outside, I eat a lot more. When I'm home, I eat much less vegetarian. People think, and I lose a lot of weight in Peru, like 20 or 30 pounds in 4 months' time, and in Italy. And the people think, well, it's because you exercise more when you're outside. No, I don't. I got COVID in Sicily 4 years ago. I have trouble walking. Here, I exercise 3 times a week, serious exercise with a bunch of people whose mothers would be too young for me to take, and I've been doing this for 15, 20 years. And the difference is, I think, correct me, is my gut fauna does not like American food. It's not the Mediterranean diet, because in Peru, same thing happens. But when I come home, I breathe deep, gain 20 or 30 pounds, feel it. And here I'm exercising a lot more. I don't get it because I'm exercising. So what I suspect, and I have like a statistical perspective, that it's not the Mediterranean diet, it's don't eat American food, not in Alaska. And what is it about that compromises my gut fauna, without being too specific, and then I go away and in 3 weeks I'm good again. And,
Yeah, it's
I know
interesting.
where I put my hat. What's the difference? And is there a simple test? Are we to the point where I can AI test here and there, over the phone maybe? But how can I figure out what the problem is? Because I know there's a problem, and I just can't figure out the solution, except expatriate.
Yeah, so is it as simple as here is more caloric dense and there is more nutrient-dense, right? In terms of the calories in the food here. I mean,
I can eat bacon and eggs in the morning in Peru, or
Oh, you do?
which I would never do here. And
Huh.
I don't trust the bacon here. I eat mostly vegetables and nuts.
Yeah.
Pollen would love my diet, and less of it here.
yeah.
Too bad.
Yeah, so we need to talk some more and then map out what you're doing in terms of what you're doing here versus what you're doing there. It must be some key. It means to what you're doing.
I buy my food at Costco and Fred Meyer's here,
Yeah.
and I go to restaurants down there.
Yeah.
But whatever it is,
Okay, I may want to travel with you.
Maybe out of respect for time, 2 questions.
Okay. That's it, I think.
That's it? Okay.
Great.
Big hand for Dr. Romel.
Thank you. I appreciate it.